Hello. This chapter explores the joints that are the articulations in our body. And we'll start off with this. By definition, articulations are sites where two or more bones meet. Now, joints are classified according to the structure and movement. But keep in mind something, movement is not necessary. Joints are the weakest parts of the skeleton. They resist crushing and tearing forces that can force them out of alignment. Now, when we talk about range of motion, ROM, this is the amount of movement at a joint. Now, you've seen this before. This is a concept map that breaks down the joints: fibrous, cartilaginous, and synovial joints. Whenever you see the red, obviously that's an immovable joint. Two bones come together, but there's no movement. Amphiarthroses are slight movable joints, as opposed to the syntharthroses, which are immovable. Diarthroses are freely movable joints. These you will commonly see with the synovial joints, whether it's plane, hinge, pivot, condyloid, saddle, or ball and socket. But let's go over this quickly. The fibrous joints, you will have sutures, which are considered seams. They're immovable. Syndesmoses, some are immovable, some are slightly movable. And then gumphoses, which we'll get into shortly. The key point is that what holds them together is more fibrous material. When we get over to the cartilaginous, yep, they have cartilage. So you have the synchondroses, such as they contain hyaline cartilage. They're immovable. But the symphyses have fibrocartilage, and therefore they're going to be slightly movable. As I said before, we have the synovial joints, which we'll get into. Those are freely movable joints. Also, this table here provides you with another breakdown of these different types of joints. I encourage you to review them to help you in preparation for the next exam. When you look at these, you will see where the suture is, and these are the fusion points between, for example, the skull bones. Gumphoses is the site where you would see teeth being held in the alveolar sites for either the maxilla or the mandible. Cartilaginous, you will see as the joint connections between basically ribs and the sternum, or the synchynosis, which is basically this attachment here. The interesting thing here is that this was really almost like a fusion point between two parts of this frontal skull bone. The amphiarthroses, the fibrous ones, consist of the syndesmoses. You would see those, for example, as attachment and slight flexibility sites within, for example, the tibia, the fibula, or the radius and the ulna. For cartilaginous, this is where you have the symphyses, such as the pubic symphyses that you see between the two parts of the coxail bones. And then, of course, then we have the diarthroses, where you have a synovial joint present, and that's where you have actually synovial fluid occupying the space between the two bones. Now, synovial joints, we'll go into this a little bit further, into each one of these. Synovial joints consist of the following: articular cartilage, which covers the bone at the joint. It's similar to hyaline, but it has no perichondrium and has more water content. The joint capsule, the articular capsule, is a sac that's enclosed, closes the articulating ends of the bones in the joint. It may be reinforced by ligaments and tendons. The synovial membrane lines the interior of the joint capsule and secretes synovial fluid into the joint capsule. The joint cavity contains synovial fluid, which acts to lubricate and cushion shocks, supports the chondrocytes of the articular cartilage. The fluid has a high viscosity due to the presence of hyaluronic acid. You do need to note that there are no blood vessels in the joint area. And that only makes sense because when you have this compression occurring between the two bones, they would basically crush or basically press down upon and block blood flow in those areas. Synovial fluid functions basically include lubrication, nutrient distribution, and shock absorption. Here is a synovial joint, and you can see how this is made up. You have the upper bone here, and you have the periosteum of the bone, which is continuous with the capsule of the joint. You have the presence of synovial fluid in here in the joint cavity. This is in contact with the synovial membrane. And then following that is the joint capsule or articular capsule. And here you have, of course, the articular cartilage. To help stabilize this particular joint, we have also in between this, or actually covering over it, a ligament. Notice that at the edge of this, the bone, you have compact bone, then you have spongy bone, and then you have the epiphyseal line, which has completely now closed and calcified. We want to be mindful of the accessory structures that you will find. With complex joints, they require additional support and stability via other structures. BURSA. These are small, thin, fluid-filled pockets formed in the connective tissue outside of the synovial capsule. Fat pads. These are localized masses of adipose tissue covered by a layer of synovial membrane. The meniscus. This is a pad of fibrocartilage between the joint bones within a synovial joint. Accessory ligaments will provide support, strengthen, and reinforce synovial joints. They will also restrict certain, well, the best way to put it is abnormal movement. So in other words, if you think about your knee, you have movement in one axis only. You don't want to have it going from side to side. You want it to go forward, behind, flex, extend, but that's it. Capsular ligaments, these are called intrinsic ligaments. They're localized thickenings of the joint capsule. Also with accessory structures, you will find extrinsic ligaments which separate from the joint capsule. You may have extracapsular extrinsic ligaments, for example, the patella ligament, which runs from the patella apex to the tibial tuberosity. Intracapsular extrinsic ligaments would be, for example, the cruciate ligaments. These run through the interior of the knee joint. To further explore your terminology involving joints, we have the term dislocation or luxation. Luxation is really when we talk about articulating surfaces that are forced out of position. Now, a lot of these displacement forces can damage the articular capsule, tear ligaments, or distort joint capsule. This can be very painful due to the nerves in the joint capsule, the ligaments and tendons. None of these nerves are really on the inside of the joint. So basically what you're getting fed information about during a situation of luxation is really more on the exterior or peripheral part, not on the interior of that joint. Let's take a look at a knee joint, for example. Here is the tendon of the quadriceps muscle. So the quadriceps muscles are up here, and you have bursa here and here, a little bit here and here, as well as a small amount perhaps here. What you'll notice also is the patella. Now notice that it's attached to the tendon of the quadriceps as well as the patellar ligament, okay? You have also on the outer side here, the joint capsule. You have fat pads here, here, here. And you will also see these fibrocartilage structures here called the meniscus, all right? You have, I've talked about the patellar ligament, but let's also talk about the cruciate ligaments right here, okay? You also have, of course, the joint cavity here filled with joint fluid. And of course, it's got to have, in part, the containment and the capability to make more joint fluid done by the synovial membrane. All right. You have articular cartilage on the tibia as well as the femur. So this allows for a extremely powerful movement, but at the same time, it's only in one axis. Anatomical organization determines the motion at synovial joints. So motion types, we're going to talk about linear motion, angular motion, rotational motion. Linear motion is the motion in straight lines. Gliding movements are the key point. Articulating surfaces of two bones move back and forth or side to side or diagonally. Angular motion, the motion in which the bones cause them to either increase or decrease angles between the bones. For example, flexion versus extension at the elbow point. Rotational motion is the motion of rotation around a longitudinal axis. Now, the problem is you cannot completely rotate due to crossing and tangling of blood vessels, nerves, and muscles around that joint. So the way to put it is this simply. When I was growing up, like we all were, at one point we would have action figures. For young ladies, they might call them dolls, Barbie and things like that. And of course, you had Major Mattel, the astronaut, or G.I. Joe. But one of the things that you could do with a lot of these basic doll/action figures or whatever is you could rotate at the hip joint the leg all the way around 360 degrees, zip, and it didn't bother anything because they popped in the leg joints into the body. Can't do that with human beings. In short, what keeps your hip from basically going completely around it in a circle is that you would basically cross and eventually tear, because these blood vessels, nerves, muscles, and ligaments would restrict movement at the hip joint. Okay? So when something happens, or even in the shoulder joint, and the shoulder joint is a shallow ball and socket, whereas the hip joint is a deep ball and socket. In either case, you couldn't completely rotate that all the way around because it would cause damage to the structures that are integral to keep that joint stable. Movement by joints is by number of axes of motion that they rotate around. So when I was talking to you earlier about the monoaxial, it's one axis. Think about it this way. Your leg at the knee joint can be extended in one axis only. Biaxial is two axes. So you could probably take your thumb and move it up and down and side to side. That's two axes. You have also triaxial. In certain joints, you can move in three axes. Now, when we talk about joints, we have to talk about the various angle motions, and they use a pencil on a pad or a platform here to give you an idea of the sliding. So we go back and forth and all in different directions. Angular, as long as that tip is still in contact with the surface. Whereas rotational is along this long axis and the tip doesn't move, and you maintain the integrity of that longitudinal axis. Now, the difference there is with circumduction. You're still in contact here, so this would be sort of the joint point. But you can take the pencil and rotate it around, but still be in contact here. Now, an example of what we would call, for example, a triaxial situation would be the shoulder joint. Okay? Superior, inferior, up, down. Lateral, medial, outward, inward. Anterior, posterior. So there you have all six axes. three axes. What I'm going to do now is spend a little time on each individual joint here. Gliding joints, also referred to as plane joints. They have a small, flat, articulating surfaces. They're slight monaxial. Hinge joints are one articulating surface is convex, one surface is concave. The movement is like opening and closing a door. It is monaxial. Pivot joints have a rounded surface of one bone that fits into the shallow depression of another bone and permits only one rotation. Therefore, it's monaxial. Condylar joints, you have an oval-shaped convex surface that articulates with a shallow elliptical cavity. This results in a biaxial joint. Now, saddle joints, the articulating surfaces has a convex and concave region. Therefore, you can formulate a biaxial joint. Finally, ball end socket joints. They are basically resulting in a triaxial joint, and it's a rounded head that articulates with a cup-like concavity. And as you can see here, here's examples of physiological sites or anatomical sites that actually have a plane joint. The clavicle with the manubrium of the sternum. There's a variety of other joints here. The hinge joint, which you can see here, is clearly with the ulna and the humerus. And so that is the elbow joint, for example. And by the way, I do want you to get very familiarized with these examples here. The pivot joint, which you can see here between the axis, which is C1, and the atlas, which is C1, and the axis, which is C2, and they're going around that dens there. So that's the atlantoaxial joint. The condylar joint, which you can see between the radius, the ulna, and the scaphoid bone here. Really, it's the scaphoid and the radius. And then the saddle joint, which you have the metacarpal bone of the thumb against the trapezium. Finally, the ball and socket. In this case, they're using the shoulder joint, which would be the scapula and the humerus. Now, in describing the motions, become familiar with these terms as they'll be critical for understanding movements of joints and muscles. Remember, we're going to go into muscles next, and this is going to help you. Now, in the next couple of charts, you're going to see they have a red dot in the diagram that indicates the location of the joint involved in the motions. These terms you do need to know, cold, hard, and fast. Now, you'll notice sometimes I put an emphasis on certain parts of the word to help clarify the difference, because it's very easy to get abduction and adduction confused. Abduction is movement away from the longitudinal axis of the body in the frontal plane. Adduction is movement toward the longitudinal axis of the body in the frontal plane. Lateral flexion, this is the movement of the vertebral column from side to side, and it's most pronounced in the cervical and thoracic vertebrae. The dorsiflexion and plantar flexion. The bending motion elevates the soles of the foot, or the bending action elevates the heels. So if you notice the red dot here, here's the point of the neck here. And so if you're going to reduce the angle, draw a line here, and you'll notice it's straight. And if you have flexion, you're going to reduce that angle between here and here. If you're going to go in the opposite direction, that's extension. And then if you can try to push it back a little beyond that, that's hyperextension. Here's another example. At this joint here, you have flexion, where instead of going straight, you're going to basically flex the arm. If you go in the opposite direction, that's extension. Here at the hip, you have your choice. You start here and move inward, and you have flexion. Going in the reverse would be extension, and then going beyond this would be hyperextension. You can see the same action on a side-to-side manner at the neck. And let's go to dorsiflexion and plantar flexion. Now, here is the red dot, the point of which you are looking at, and that's where the joint would be. So if I'm going to do dorsal dorsiflexion, I'm going to have an ankle flexion here, because what you saw here was sort of a straight line, and now you're reducing that angle. The plantar flexion, plantar being the bottom of the foot, you're having an ankle extension, and so you're going in the opposite direction. Now, abduction, adduction, and circumduction. Abduction is movement away from the longitudinal axis of the body in the frontal plane. Adduction is movement toward the longitudinal axis of the body in the frontal plane. We've talked about that. And then also we have to deal with circumduction. This is a conical movement of the body part, such as a ball and socket joint or the eye. The movement of the body region in a circular manner in which one end of the body region is being moved stays relatively stationary while the other end describes a circle or moves in a circular pattern. One thing to keep in mind, in spreading the fingers and toes, you abduct them as they move away from the central digit. Bringing them together adducts them. So let's take a look at this. Here we have abduction away from the central line. Adduction is coming inward. You can do this at the wrist. Abduction in one way away from the central body. Adduction in the opposite direction. Same thing with the leg at the hip joint. Now, this is circumduction. At the shoulder, it does not move, but what you do is this big, long, circular movement here. And what do you see? A circular movement by the rest of this part of the body, but the central part doesn't move. Let's do this also with the wrist. Abduction moving away from the central, if this would be the central axis. Adduction if you're heading toward it again. Again, let's look at the central digits here. If this is the central digit and we're talking abduction, adduction with the fingers, if we bring them all close together, that's adduction. If we spread them all apart, that's abduction. Rotational and special movements. Now, here's the thing. We've gone through the basics, but now we're going to see certain parts of the body that allow us to have specialized movements, in part because of the unique joints that are present there. Right and left rotation of the head. You're turning the body left or right around a midline of the body, and the best example of that is the atlantoaxial joint. Remember, the joint that exists between C1, C2. The shaking of the head, no. Limb rotation is turning of a limb about its axis of rotation. Now, this is, remember where we said, in the beginning of the course, I wanted you to get down terms like medial and lateral and all these other ones. Well, here we're using them. The medial, otherwise known as internal rotation movement, the anterior surface of the moving part is brought towards the median plane. The median plane is coming toward the body. Lateral or external rotation movement, that's the anterior surface of the moving part brought away from the medial plane. Pronation, supination. This is the rotation of the radius around the ulna at the proximal and distal radial-ulnar joint. Pronation, turning the wrist and hand so the palm faces posteriorly. Supination is doing the opposite, turning the wrist and hand so the palm faces anteriorly. Here you see this. Now, if you notice, part of this is because of the participation at these two joints, the proximal radial-ulnar joint and the distal radial-ulnar joint. Supination is bringing it up so that you see the palm anteriorly. The opposite is pronation, where you see this oppositely. All right? So you're moving it to the posterior view. Right and left rotation, that's at the atlantoaxial joint, which I talked about before. Lateral, medial. If you're moving the arm toward, here's the midline, you're going into medial or internal rotation. If you're spreading it outward, this is lateral external rotation. Now, a couple of other special movements. For example, opposition. The thumb is brought over to touch another digit. Protraction and retraction. The mandible moves anteriorly or the mandible moves posteriorly. okay? Eversion, inversion, the sole of the foot moves away or towards the medial plane. Depression and elevation, this is where we get to the jaw again. The mandible moves inferiorly or the mandible moves superiorly. So let's look at these examples here. Here's opposition. Notice that the thumb is able to touch pinky finger, ring finger, etc., middle finger, etc. Eversion, inversion. If here is the central axis and here would be our red dot, eversion is moving the foot outward, okay? Or inversion is moving it inward, okay? And then we have the jaw. Now, the TMJ joint would be the joint that we're looking at here. Retraction is moving that jaw back. Protraction is actually moving us forward. You notice you heard that in my voice because I'm saying the words with my jaw really far out. Sounds funny, but anyways. Depression, elevation. So the jaw can drop down, almost like, wow, did you see that? And then elevation is moving it up. Okay? Now, comparison of axial and appendicular skeleton joints. Keep in mind that most joints are named for the bones involved. Most joints in the axial skeleton permit very little movement. The focus will be on the vertebral column. The typical appendicular joints allow for a greater range of motion, yet joints are typically weaker than axial skeleton joints, okay? So what I'm saying here is the joints that you find in the appendicular skeletal joints, you're going to find greater range of motion. They are weaker than the axial. The axial will also have usually a very limited range of motion. Okay. Now the focus will be on the shoulder, hip, elbow, sorry about the typo, and knee joints. So let's take a look here. If you look at the joints of the skeleton, oh yeah, you've got sutures here, temporomandibular joint, atlanto-occipital and atlanto-axial joint. Great. Joints of the thoracic cage. Intervertebral joints here. The lumbosacral joint here. And then the sacrococcygeal and intercoccygeal joints. But you notice not as much movement here. Well, when you look at over here, the joints of the appendicular skeleton, the sternoclavicular joint, not a lot, but something. The shoulder joint, lots of movement. The sacroiliac joint, which is the two bones forming here, not much movement at all. It's more like, almost like a suture. The elbow joint, a great amount of movement. The proximal and distal radial ulnar joints, those are where we had the supination, pronation. The wrist joint, we had movements and various joint formations there. We have the pubic symphysis, which really doesn't have a lot, and remember that that's based out of cartilage. Joints of the hands and fingers, a certain amount of movement there. The hip joint, a great deal of movement. The knee joint, a great deal of movement. The ankle joints, somewhat the same as what you would see with the wrist joint, and then we have the joints of the foot and toes. Now, as I've mentioned to you before, the vertebral column has three types of joints. The syndesmoses, which is the fibrous joints of the vertebral column, and this includes the vertebral ligaments. I'll show you the diagram in a second. The synchondroses, which is the intervertebral joints of the vertebrae united by the fibrocartilage structures called intervertebral discs. You've heard of that before. And then synovial. This is where you have vertebral synovial joints between bony processes of adjoining vertebrae. Articular processes go from superior to inferior processes. We have the intervertebral disc consisting of the annulus fibrosus. This is really important because this is where you hear some people talk about, okay, I have a ruptured disc. The annulus fibrosus is the outer ring of fibrocartilage. You have cartilagen fibers that attach to the disc and they attach to bodies of the adjacent vertebrae. Then we have the nucleus propulsus. This is a soft gelatinous core that provides the disc with resilience to absorb shocks. Okay, here's where the nucleus propulsus is. This is a superior view. Here's your annulus fibrosus around here. What happens if we have a rupture of that disc? This is going to start literally getting pushed out and beginning to put pressure onto the vertebral spinal cord nerves. But let's take a look at the vertebral ligaments. We have the ligament flava, the posterior longitudinal ligament right here, the interspinous ligament right here between the different spinous processes, the supraspinous ligament, which is over here, and the anterior longitudinal ligament, which basically is a covering over the vertebrae. You have also a posterior longitudinal ligament, which is kind of like a cushion here between the bone and what would be the spinal cord area. Okay? Now, this is where I'm going to get a little bit more into depth here with things. Intervertebral disc disease, IVDD, is a painful condition caused by disc degeneration that affects the spinal nerves. Usually you'll have bulging disc. This is a longitudinal vertebral ligaments have weakened and compressed the nucleus propulsus, and therefore it bulges into the vertebral canal, pressing on spinal nerves. It's very painful. Okay? There has been some developments. One of them literally is to put a thin wire into the area where the nucleus propulsus is, kind of space apart the vertebrae, and they heat the wire. Now the wire, the person isn't going to feel anything, because really you wouldn't have nerves in the center of the nucleus propulsus. But what it does is it causes it to congeal and harden up a little bit so it doesn't escape as much. A herniated disc is where the nucleus propulsus breaks through the annulus fibrosus and compresses on the spinal nerves. It can result in pain and paralysis. Then we have two others that are very important. Osteoporosis, which is a reduction in the bone mass. Now keep in mind this, if we've talked about how the vertebrae are so important and how the body of the vertebrae are thickened and increase in size as they move down or inferiorly down the vertebra canal. So you go from cervical to thoracic to lumbar, and lumbar, they're huge. They have to handle the body weight. We can end up, though, with reductions in bone mass due to declining hormonal levels, and this can result in compression vertebral fractures. In other words, in that body will start now literally starting to crack, and it will break down. In some cases, it will be almost crushed. And sometimes that's where you get into the concept of having what is called a spinal fusion. Fusion between one good vertebrae superior to the compression and one inferior to the vertebra that has the compression. Osteopenia. This is inadequate ossification due to aging, low calcium diet, and smoking. As you can see, here's the normal intervertebral disc. Here is the bulging disc. So if a nerve is coming up against this, this is going to be having a great deal of pressure on it. If you have the nucleus propulsus break out of the confinement from this annulus fibrosus, you're now going to have a compressed area of a spinal nerve, which an individual will find very, very painful, or will find almost like a paralysis. Remember, these are the spinal nerves here and here. Now, with normal spongy bone, this is what you see, the structure here. This is the spongy area. But if you notice a normal spongy bone with osteoporosis, this looks as if it's filled literally with holes and divots. And so it's not maintaining its mass, and therefore it becomes weakened and can become crumbly. And that's what you see here with the compression fracture of the vertebral disc. Notice that all these small fractures here have led to a decrease in the height, a decrease in the mass, and as a result, now you have an unevenness in the straight symmetry of the vertebrae. And you have further situations of compression possible here. So what they usually will do is, in some cases, is a spinal fusion where they basically attach restrictors, and they basically hold this vertebrae and this vertebrae together, which will prevent any movement sidewise or other for this compressed fractured vertebrae. Now, we're going to move into several of the joints, particularly ball and socket joints first. This is the shoulder joint, otherwise known as the glenohumeral joint. It's the greatest range of motion, most frequently dislocated joint. Its stability is sacrificed for mobility. Okay, so it's a shallow ball and socket. The articulation of the head of the humerus with the glenoid cavity, as a result, you have a shallow cavity in the glenoid. Aside of the articular cartilage, the fluid-filled joints, you have accessory structures of ligaments, bursa, menisci, fat pads, which enhance the stability of the joint. The stabilizing ligaments include the glenoid labrum, the acromonio-clavicular ligaments. You have two coracoclavicular ligaments. You have also the coracoacromonial ligament, the coracohumeral ligament, and the glenohumeral ligament. Now, as I mentioned in lab, I want to reiterate this to help you. When we start talking about certain prefixes or suffixes, words mean things. Coraco is an attachment to the coracoid process. Acromonia, this is an attachment to the acromonium. Humeral is an attachment to the humerus, and clavicular is an attachment to the clavicle. Here we have the shoulder joints in several different approaches. I'm going to go through them quickly, but I want you to be mindful of this. Now, there is a tendon here of the biceps brachii, and what you end up with this is this sort of tendon sheath. It's like a bursa, but it allows for a rolling effect as the shoulder is moved, so that this ligament doesn't come in contact with this tendon of the muscle. Notice that you have all of the ligaments stabilizing the shoulder here, 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 and here, because you have to have some stability between the scapula and the clavicle, because it's really the clavicle that attaches right to the sternum. That's the only real attachment. Remember that the scapula is not attached to the back. It's not attached to the ribs. So it's held in place by a combination of muscles and ligaments. So far, so good. Let's go over to the side here. And here you can see the actual serous arrangement here. The synovial membrane is right here. We have the deltoid bursa right here. We have an articular capsule on the outside. And so we have synovial fluid in here. You have some synovial membrane here. This is the glenoid labrum, okay? We have the articular cartilages here and here. And then, of course, we have the various ligaments, such as the coracoacromonial. And we have the coracoclavicular, okay? Now, this is as if you're looking straight in to the glenoid cavity. Articular capsule you can see, the articular cartilage you can see, the glenoid labrum you can see. You see where the scapula is. This is part of that part here, and of course the acromonium. You see the clavicle over here, and now you start seeing all of these other very important structures and the tendons of them, such as the supraspinous muscle, the infraspinous muscle, etc. These are going to play key roles in helping maintain the stability as well as movement. The biceps brachii tendon is right here. The coracohumeral ligament right here. Notice that they cut some of this so that you can see it effectively. The glenohumeral ligaments here and here and here. And of course, you've got the teres minor muscle here and the subscapularis muscle right here. All of this is to maintain stability and mobility at the same time. Next, we're going to deal with the hip joint. This is a diarthrosis that allows flexion and extension, adduction and abduction, and rotation. It provides durability and stability for supporting and transmitting all the weight of the upper body. But you have a deep cavity of the acetabulum. The stability is achieved by ligaments: iliofemoral ligament, pubofemoral ligament, ischiofemoral ligament. You also have the acetabular labrum, which is a fibrocartilage pad in the acetabulum. You have an acetabular notch. You have the transverse acetabular ligament, which crosses the acetabular notch and fills in a gap in the inferior border of the acetabulum. I'll show you that in a second. And then we have the ligament of the femoral head, which is also known as the ligamentum teres. This attaches to the ligament of the femoral head. Here's the ligament teres. Here is that transverse acetabular ligament. Here is the acetabulum as a whole, with you having articular cartilage, the iliofemoral ligament, and you have also the acetabular labrum. Okay? And what you have to understand is this: if you look at these images here, you can't even see the head of the femur. Why? Because it's totally wrapped and connected with various reinforcing ligaments, which attach to the greater trochanter and the lesser trochanter, as well as attach to some of the aspects of the the ilium of the bone of the coaxial bones. Remember, there's 3 of them here. So you've got these reinforcement ligaments here, and you have them attached over here. They're all anchoring to provide stability. Okay. The elbow joint. It's a complex hinge joint as it involves the humerus, ulna, and radius. It is very stable due to bony surfaces of the humerus and the ulna interlock. The single thick articular capsule surrounds both the humeral ulnar and the proximal radial ulnar joints. And you also have articular capsule that is reinforced by strong ligaments. I'm sorry, there was a typo there, but it's strong ligaments. This is including the radiocollateral ligament, the annular ligament, and the ulnar collateral ligament. If you take a look here, just with the bones, you will see where the oleocranon meets into the oleocranon fossa. So you have the ulna fitting into a little pocket here on the humerus. You have the humeral ulnar joint, which is right here. Okay? You have the humeral radial joint right here. Notice that that's the flattened part here. Between the radius and ulnar, you have a proximal radial ulnar joint right here. Sorry about that. Now, if you look down here, you've got a radiocollateral ligament over here. The annular ligament goes around. You have the capitulum of the humerus down here. And then you have this interosseous membrane that provides further stability between the radius and the ulna. That's the lateral view. Let's do it on the medial view, the inside here. And you can see the tendon of the biceps brachii muscle coming out from here. You have the articular capsule over here, the medial epicondyle here, which is attached then to the ulnar collateral ligament, because here's the ulna. You've got the oleocranon of the ulna right here, and it's further stabilized not only by the annual ligament. Annual is like ring, okay? But you have several of these put together, and they basically provide for extreme stability. Now, knee joint. It permits flexion, extension, and very limited rotation. Actually, it's a composite of 3 separate joints: the femur and tibia, at the medial condyle to the medial condyle, and the lateral condyle to the lateral condyle. The patella and the patellar surface of the femur. It is interesting to note that the fibula does not play a role in the joint at all. This is different than what you see at, let's say, the elbow joint. Now, you have the anterior cruciate ligament. Crucius means cross. So you have one ligament that starts to form this cross, the other one, which is the posterior cruciate ligament, the PCL, That forms the other part. And these limit anterior and posterior movement of the tibia and maintain alignment of femoral and tibial condyles. This is important. You have menisci, the medial and lateral. The fibrocartilage pads, they act as cushions and provide lateral stability at the joint. You don't want it going toward the medial end or toward the lateral. You want to keep a nice, simple, monoaxial stability. Ligaments. You have the fibular collateral, or otherwise known as lateral collateral. That makes sense. Lateral, and provides lateral support for that ligament. The tibial collateral, also called the medial collateral, and this provides medial support. And then we have apophyleal ligaments that extend between the femur and the heads of the tibia and fibula. So let's take a look at here. Here's our patella. Here's our quadriceps tendon here, and it's attached down to the patella ligament down here to the tibia. So there's one part here. But notice that you're going to have the fibular lateral collateral ligament here, which attaches fibula to up here, the femur. You will have a tibial, that's a medial collateral ligament, down here, which of course attaches tibia to again the femur. All right. Then we go into the back part, the posterior, and you notice that you have apophyleal ligaments, which attach tibia again at an angle to the femur, fibula over to the other side of the femur. You have bursa tucked underneath here and here. The joint capsule will be in here. The fibular collateral ligament is down here. The tendon of the biceps femoris muscle has been cut away, but you can see how that's playing a role. And then you have, of course, the fibia, the tibia. Now, let's strip away some ligaments and look even deeper. Here you notice that the patellar surface of the femur, articular cartilage, you've got the lateral condyle, the medial condyle, which happen to fit into these nice menisci. Okay, so if this is the medial condyle, it fits into the medial menisci. If this is the lateral condyle, it fits nicely into the lateral menisci. Of course, you've still got that stability from the fibular collateral ligament and the tibial collateral ligament. Notice in here we've got our X, okay? Posterior cruciate ligament, anterior cruciate ligament. But let's take a look here from the posterior side. Anterior cruciate ligament is over here. The posterior one is right here. Notice they're all attached in one sense or another to the tibia. Provide stability by attaching themselves to the femur. Okay. Tibial collateral ligament is here. Fibular collateral ligament is here. We've got the menisci, the medial and the lateral here. Okay. Now we're going to talk about disorders or diseases of joints. Rheumatism is a general term for pain and stiffness affecting the musculoskeletal system. Arthritis encompasses all rheumatic diseases that affect synovial joints. Always includes damage to articular cartilage, but specific causes may vary. Osteoarthritis is also referred to as degenerative arthritis, where you're having a degenerative joint disease, the most common form of arthritis, and it usually affects patients over 60, caused by the cumulative effects of wear and tear at the joint surfaces. All right? Keep that difference. Gouty arthritis. If you're hearing the word gout, think of uric acid crystals, and we'll get into this. This is a form of inflammatory arthritis that develops in some people who have high levels of uric acid in the blood. The acid can form these needle-like crystals in a joint, cause sudden and severe episodes of pain, tenderness, redness, warmth, and swelling. Those that have usually, you have to understand this, and we'll probably mention this much later on when we get into AP2 in the urinary system. The way that we get rid of nitrogen waste is making urea, which is a water-soluble compound. If you've ever had a car where the bird went poop on it, that whitish crystalline stuff doesn't seem to wash off. You got to kind of scrub it off or use more effort on it. That's because birds, reptiles, etc., deposit their nitrogen waste in a water almost insoluble material called uric acid. That's what they release, and uric acid does exist a little bit in humans. It's basically pushed forward by certain dietary demands. But here's the key. If you have a buildup too much, the uric acids no longer are going to be soluble in the blood and in interstitial tissues, but basically they start depositing out, and they come out of solution and they start forming crystalline structures, and this can be very, very painful. Usually when someone has gouty arthritis, they are put on certain drugs that enhance uric acid excretion through the kidneys, as well as give them a diet where they're not able to produce as much uric acid. Here's a normal joint. You can see the fine detail of the articular cartilage here with the lacunae. This would be an arthroscopic view of normal cartilage here. Now, here is an arthritic joint where you have fibrous remains of the articular cartilage. You have degeneration of the articular cartilage. Notice that the lacunae are much large, almost stretched, some of it because of deterioration of the tissue. The extracellular matrix is warped and distorted as opposed to here. And as a result, in this arthroscopic view of the damaged cartilage, you can actually see where it's almost like there's impacts, where bone underneath is going to be exposed as the cartilage is being destroyed. Okay, so you have bone on bone contact, which is not good. Finally, we have a couple of other issues we want to bring up. Rheumatoid arthritis, that's a form of arthritis due to the body's immune system attacking its own tissue, including joints. An arthroscope is a fiber optic scope which allows viewing the joint cavity. Finally, we have artificial joints, which are used to replace damaged joints. There are limits to high impact activities as a result. The newer models can last 15 years for the patient. Here's the question, can they take an MRI afterwards? Think about it. What are you told when you take an MRI image? Do you have any metal on you? The reason being is that magnetic resonance imaging has an extremely powerful magnetic fields. If you had somebody go into that medical field, that magnetic field with an implant, the implant could literally be ripped from their body. So one of the limitations that when a patient gets a metal joint, and these are usually metal, they may have some plastic or polymers with them, but they definitely have some metal in them, is they cannot take an MRI from that point on. Furthermore, they may set off, if you've ever been to an airport and they have the metal detectors there, they usually have to carry a card or a letter from their physician that says, hi, if we set off the metal detector, it's not because my patient is carrying a bomb, it is because she has an artificial hip or an artificial knee, etc., etc. There is hope. They have been working on attempts to regrow cartilage tissue, and there's been some progress. Perhaps someday they will be able to take small samples from a patient, regrow a lot of it, and reimplant it into the damaged areas with subsequent healing and growth and restoration. But remember, cartilage tissue, as opposed to bone tissue, is much slower metabolically and much slower in growth. Here is the ACL, here's the meniscus, here's the PCL, here's the femoral condyle. This is because they were taking a look at this via an arthroscope. Here is an MRI, and you can see the damage that's caused to the structures here. You have the lateral condyle here, the medial condyle here, the patella, And the nice thing about MRIs is that you can take small slices to examine the detail of damage to tissues, etc. Here are some examples of artificial shoulders, knee, and artificial hip. Okay? Well, we're done with this chapter. What are you to do left? Peruse chapter review outline on pages 309 to 310. Complete the review questions on 311 and 312. Complete review sheets on pages 298 and 308. The next chapter we're going to go into is on skeletal muscle tissue. And I hope you have a great day.